Bienvenue. Welcome to this round table. Ted, Alan didn't mention that Ted and I have been doing a couple of these round tables over the past month, and every single time Ted usually goes first. So this is the first time the Canadian gets to go first. I know that doesn't happen much, but I'm very happy that Alan has given me the first word, particularly at this time of the day and here at Princeton. I was struck by the fact, the first fact that reminded me of something that happened to me in graduate school. When I tried to find Canadian studies on campus, Alan, this afternoon, I was really impressed by the way I could just walk into the building and sashay my way around there, whereas to get into the library was a really complicated deal. So that goes to show you something about Canada and Canadian studies. It's open to the world, as usual. The anecdote that I tell about my days as a graduate student, which was not in this illustrious university, but at Northwestern University. So for those of you in Princeton who don't know where Northwestern is, it's kind of halfway between here and the West Coast, just north of Chicago and Evanston. And my first experience in the United States was that I arrived in Chicago, and I was given a student visa in which it was stamped non-resident alien. To which I said to myself, well, wait a minute, I'm not an alien. And I thought it was very interesting that in the United States, anyone who's not from the United States is not a foreigner or a visitor or something else, an alien, outer space, something so completely strange and different that as to be completely out of this world. And I think that's something to be said about, what lessons can the United States draw from the Canadian experience? Well, the first lesson, I guess, is that there are lessons to draw from other experiences, and I think that's an important lesson, and certainly one which many Americans have already learned. But it's in that spirit, then, that I'd like to begin this particular debate with Ted. The first lesson, I think, when we talk about Canada and the United States compared to one another, is that it's very interesting to note that universal, affordable, publicly funded, accessible, comprehensive, and portable health insurance is in effect possible. And it's possible in a place not that far away from the United States, and in a place that doesn't look that much different than the United States, namely Canada. So I think that the comparative evidence shows that rather than a genetic predisposition to having one kind of a health insurance system or another, it is, in effect, possible for a model of this sort to emerge. And so the divergences between the two countries are based on something other than simply the fact that Canadians are kinder, gentler, or whatever moniker you want to use, or that Americans are individualistic and very firmly rooted in their ideas of personal liberty. I think that if you think about it, and you look at that comparative evidence, it becomes clear that the divergence between the two countries and the fact that Canada has a very different system is really about political choices and policy debates that happened for different reasons, and particularly almost at the same time, but went in different directions in the two countries. And Alan mentioned my book. In that book and in the analysis that I have done of Canada and the United States, and Ted has done this as well on many occasions, looking at the US and Canada, looking at the US compared to countries in Europe. It's very clear that what's important in those political choices have to do with interest groups, partisan politics, public opinion, and all of these things play themselves out differently in the two countries. But if you look even deeper than that, you see that there are a lot of similarities in political debates, or there were a lot of similarities in political debates. There were a lot of similarities in the way that public opinion was divided on this issue. So it's not that it's something that cannot happen in either country or the other. The other thing that's interesting in thinking about that is that what comes to be quite apparent is the transmission routes for policy alternatives were very different in the two countries, and so was the political voice given to those various alternatives. And institutionally speaking, of course, the biggest transmission routes, if you will, to the road to health insurance as we know it in Canada happened through federalism, the fact that provinces became laboratories of democracy in a way in terms of the innovation that they attempted in healthcare, and in particular one province, which happened to be governed by the only social democratic government in power in North America, and also the parliamentary system, which allowed, again, a minority voices to come through on the left, but also with parliamentary or party discipline in the parliamentary system, allowed rather, whoops, now you can hear me. Ooh, did anyone hear anything I said before, until now? Good, okay. Allowed many decisions to be made that might not otherwise have been made in the American context. The corollary to that first lesson is one that I'm sure none of you in this room have to be taught, and certainly not my, my two co-speakers this afternoon, which is that politics matters. And so that if we think about why it can be done in Canada, and it has not been done in the United States, the fact that politics matters, I think, is a very important point that we should never really put on the back burner. The second big lesson for the United States from the Canadian experience is that trade-offs are important. And trade-offs are different in the two healthcare systems. I'm very amused when American friends tell me, oh man, I wish I lived in Canada where healthcare is free. It ain't free. It ain't free up there. We're paying, or I am, many of us in this room who are Canadians are paying through the collective nose. It's not a free ride in terms of what we pay for and what we get. And I think that that's something that is also useful to remember. Whichever way you slice the health care pie, someone ends up paying. In Canada, the way that we pay for health care is very different. First of all, health care is made affordable for everyone by the fact that it's financed through general revenues. So people who are on the higher end of the income scale may say that it's becoming inaffordable in the sense that they're paying taxes that are quite too high, but still, the basic principle for the financing of healthcare in Canada is to socialize the costs of healthcare, to, in effect, make everyone pay and allow people to then use the services when they need it. It's very important to stress the use the services when they need it, because the trade-off there is between cost and need, so that everyone pays into the system, but the priority list for who has access to those services is based on need, which means, because in any healthcare system you're going to ration on some basis, whether it's on money in the United States, or the kind of money you have to pay for the insurance coverage you can get, or on the basis of need, someone is going to end up waiting. And in Canada, we've decided that the person who ends up waiting is the person who is considered to have the lesser need, or considered to have a condition that is not as life-threatening, urgent, or emergent as the next person. It also means that the trade-off is that the healthcare system can't cover everything. And what that means is that some things are not covered by the public system. And Canada has a very curious arrangement in that regard. And I don't say curious as in strange or weird. I mean curious in that it differs from most other publicly funded health insurance systems across the world, in that Canada has decided, or the Canadian provinces, I should say, in Canada have decided, that whatever is covered in the public system, what we call the Medicare basket, is covered at 100%, at first dollar. So no money changes hands. It's 100% coverage, first dollar coverage, for everything that is considered medically necessary under the terms of that Medicare basket. But what's not covered is not covered. So most provinces don't cover dental care. Not all provinces cover outpatient prescription drugs. All of these things, Canadians are obliged to pay for supplementary private insurance. So the other thing to remember when we think about the Canadian experience is that the private market exists in Canada, but it exists at the margin of the healthcare system, and it exists for whatever is considered not covered under the public system. There is a wall between public and private in Canada, so that everything that is publicly funded can only be publicly funded. So the doctors can't play in both sandboxes. They must, in effect, choose whether they are going to be publicly reimbursed by a public authority, or whether they choose to be completely outside of the healthcare system. This brings up two things. One is that, speaking of doctors within the public system retain their professional autonomy. So David Naylor, our colleague who is now president of the University of Toronto, has written a very important book on this called Public Payment, Private Practice. in which he states what's really interesting about the way doctors are organized in Canada is that doctors retain their professional autonomy. They are, in effect, still in private practice in terms of their relationship to patients. They are paid on a fee-for-service basis. And what makes a lot of health reformers go red in the face in Canada is that this is even true for primary care, where it's probably not the best way of organizing the primary care system. But doctors have, in effect, won that right to professional autonomy and, in effect, in some respects, financial autonomy, in return for allowing the socialization of the costs of healthcare. So the doctors, in effect, have a lot of power in the Canadian healthcare system in terms of the choices they can make. However, the choices are still within a framework that is governed by a collective will and at the end of the day is still publicly administered. So that political struggles are still important in the Canadian healthcare system. And those political struggles have to do, of course, with funding. Because when you socialize the costs of healthcare, you increase the burden on the public purse. And so right now in Canada, we're engaged in a very interesting debate. I'm sure Ted would say it's a cuckoo debate about the fact that governments are saying we can't afford healthcare, so we have to figure out other ways, including private payment mechanisms, to bring into our healthcare system so that we can make healthcare affordable, which is kind of counterintuitive because when you do that, you make the overall costs of healthcare more expensive, but governments are only worried about how much it's taking up of their particular budget at one point in time. The third important lesson for the United States from the Canadian experience is something I would call the Canadian paradox. And that is that the public consensus around our universal health insurance system is both very resilient and very fragile. And the reason for that, or what I mean by that, is that collectively speaking, Canadians are quite supportive of the values that underpin the healthcare system. They believe that this need principle is an important one. They believe that by collectivizing the risk and the sharing, or sharing the risk, pooling the risk and the cost, these are ways of making a healthcare system stronger, of making sure that everyone has access. And most Canadians believe that universal access is a good thing. However, at the same time, this is coupled or put into context against individual needs. And the fact that Canadians believe in these collective values, but at the same time, they're not willing to wait for a procedure, or they find it hard to understand why their elderly parent has to wait for a hip replacement, or why certain protocols or certain procedures are not covered under the health insurance system. So there's still a consensus about who should be covered, which is everyone. Everyone believes that everyone should be covered, but there are questions about what should be covered and questions about when. That is to say, who should be at the front of the line and how financing itself should be organized. And I point this out to you because in the past 10 to 15 years in Canada, there has been an erosion in the confidence that Canadians have in their healthcare system. And some of this has been due to the fact that politicians have played political football with healthcare, and they have now they realize they've done so at their own peril. Because as financing was slashed in provincial health budgets across the country, that was pushed on to doctors and hospitals who pushed it onto patients. And of course, the upshot was that many people felt that there was undue waiting and that there were undue cuts in the healthcare system. People have begun to wonder whether the system is sustainable, what in fact should the array of perhaps public-private partnerships be, and to what extent some people should be allowed to pay, if they have the money, they want to pay twice, if you will, for their healthcare needs. There's also a big debate about where decisions should be made, and that's the political debate about whether or not decisions should be made at the federal level, because the federal government allocates quite a bit of money to help the provinces pay for their healthcare system, or whether the provinces should have free rein in doing what they want in healthcare, because they, in fact, have the jurisdictional responsibility. They pay the lion's share for healthcare, and also they sometimes feel constrained by the Canada Health Act, which is the federal government's guidelines to the provinces, so that in order for provinces to receive funding, they must ensure that their provincial healthcare systems are universal, comprehensive, publicly administered, that they impart equal access and that they are portable across provincial boundaries. And not all provinces do this 100% of the time. I think that bringing up this question about the resiliency and the fragility of the consensus around healthcare is something I get a lot of flack in Canada, but it's true that the debate has changed, and I think irrevocably, over the past 10 years, and that's why when we talk about the challenges facing the healthcare system in Canada, they may not seem as acute as the ones facing the United States, but we still are, in effect, at our own type of crossroads in Canada. And finally, let me just say one thing that often gets overlooked in policy debates. It doesn't get overlooked in public health debates, but it does, and since I'm at the Institute for Health and Social Policy, I thought I would bring it up because everyone spends their time, studying social determinants of health all day long around me. But one of the things that the United States can learn from Canada, and indeed from many other publicly funded healthcare systems, is that universal health insurance does have an impact. So while the Canadian healthcare system is not a panacea for everything that's wrong with the United States healthcare system, nor is it the evil empire that must be avoided at all costs. If you think froidement, if you think objectively about the impact that this universal health insurance system has had, it has had an impact on health outcomes. It has had an impact on health spending. Health spending in Canada is considerably lower than in the United States, even though, as Ted points out very eloquently in the piece that he wrote for the Woodrow Wilson Center in Washington, they started out at very similar places. Access to health care has increased, particularly for people who would otherwise not be able to afford that kind of access. There is perhaps not a complete success in terms of inequality and access to health in that regard, but certainly people of lower and even middle income are able to afford the kind of care that they might not otherwise be, or they might have been able to afford in, for example, the American context at a much higher sacrifice in terms of cost. It does, some people would argue, though I don't have the data to share with you, but some would argue that it does contribute to social cohesion, particularly in our larger cities. It does change the healthcare system, and it has changed the way doctors see their role and their relationship with patients. And I think that even though many doctors are dissatisfied with the way the healthcare system is emerging in Canada, they're dissatisfied with the fact that there is rationing of care, that there are limits on some technological goods in the system, many of them do believe in the same values that underpin that healthcare system, and that, in effect, comes through also in medical education. There's also, of course, the fact that the system is, to a large degree, efficient in its administration. Though there are lots of challenges and issues still outstanding, it is, in effect, an efficient system overall. Though there are a lot of things that I could say to raise in this context. I think that I'll wait then, because when I arrived today, I said to Alan, I'm prepared to talk about what Canada can learn from the United States. And Alan said, no, we want to know what the United States can learn from Canada. These are the 4 big lessons, and I'd be happy to engage with Ted and in questions later on. Thank you very much.
When we've done this dialogue before, is this working all right for you folks? We've actually sat at the table together since we have only friendly differences about this matter. It's a little bit more formal. Is this normal at Princeton? You have to stand up to have a word in. We could sit as well. We will sit later. Truth in advertising would have to have me say that my differences with Antonia Maioni are modest by my differences with many others in American politics. So I'm going to take a slightly different posture. What I want to do in the time allocated for me at the outset is, I think, 4 things. One is I want to re-emphasize what Antonia alluded to, which is that if you went back to the United States in 1960 or 1964 or 65 when Medicare began, the differences in the conception of what would count as the dominant picture of healthcare reform would be practically identical in both societies. In other words, the degree to which in that period of time there was not uniform agreement but substantial consensus that medical care was a merit good and it ought to be distributed without ability and willingness to pay as a major element. That stood in back of Medicare in the United States, and it certainly stood in back of the hospital insurance in Canada in the late 50s and the medical insurance in the late 60s. The divergence that Antonia referred to is the second thing I want to talk about. The third is that I want to say something about the distorted views we have of Canada from the United States and the Canadians have of the United States, which hasn't really come up yet. But it's been a constant theme of the research I've done over the last 35 years. And then I want to say something about what I would take to be in 2008, the lessons we should concentrate on in dealing with Canada. But before I do any of those four things, I want to tell you a story. And the story has to do with the theme of my remarks, which is the gap between appearances and reality, which I think are wildly obvious in Canadian-U.S. understandings of medical care. And the story has to do with a nun in Toronto, Sister Mary, whose job it was to be in charge of home health services in the Diocese of Toronto. And one Monday morning, she went off to work, and she ran out of gas about 50 yards from a gas station in the suburbs of Toronto. And she went right away to the gas station and asked the attendant, could I possibly borrow a gas can so I could get on with my home health work? And the attendant said, Sister, I'm terribly sorry, but I just gave away the last gas can. Now, there were two men who were around the area where Sister Mary had run out of gas. She went back to that car. These two men said, could I help you? They said, no, I'm all right. She opened up the back of the car, took her toolkit out, and took out of that toolkit a bedpan, which was part of her instrumentation, and went back to the gas pump, poured gas into the bedpan, came back to her car, and started pouring gas in her gas can, right, in her car. And these two guys were looking with puzzlement. And finally, one said to the other, if that car starts, I'm converting to Catholicism. That's roughly the way I think Americans and Canadians understand each other's medical care system. Right? That is, they don't know very much about each other's medical system, but they have strong views of it nonetheless. And that produces a remarkably distorted discussion, both about Canada medical care and about the United States, let alone drawing lessons across them. So I want to then say now a word about the divergence. It's when you think back over these last 40 years from a very common value base, in my view, to be sure, institutionally different because of the role that Saskatchewan played in a trial run, so to speak, about what you would have said, I think, if you were on both sides of the border, you'd said, you know, an old-fashioned Blue Cross Blue Shield plan is really what people on the whole would like to have. And basically, that old-fashioned Blue Cross Blue Shield plan is what we did for Medicare. That's where the model came from. Not exactly first dollar coverage, but basically taking medical care decisions out of a rationing device by income. Now, what I think it's fair to say in the United States, the presumption of those reformers in the 1960s, and I worked in Medicare when it first began, my bosses, Bob Ball and Wilbur Cohen and all those who worked with them, their presumption was that they were going to be expanded in steps. It was going to first be children and gradually squeezed. The fundamental assumption was that this area of life was to be protected by social insurance, which is the socialization of insurance, not the socialization of the delivery of care. And that was what was going on in Canada too, but they started there with a service rather than a population group. The service was hospitals in the late 50s, leaving a completely obvious gap in the coverage for the hospital sector. We, however, did it differently. Veterans after the Second World War, then poor elderly in Kerr Mills, expansion to all the elderly in 65, renal failure in the 70s along with disability. In effect, by expanding by population group, we made it all the more difficult to say what's next, whereas it was obvious in the Canadian context, in my view. That's my view. It also had, of course, something to do with Vietnam. It had something to do with urban riots, and it certainly had a lot to do with the inflation and stagflation of the 70s. But I would say now the following, I'd make the following proposition. It would be very hard in Canada of the year 2008 to enact Medicare, their Medicare. And the reason it's difficult in the United States to enact Medicare now is the divergent path we took from one that in effect ate up the prominent political support until we now face ourselves thinking about, in the election of 2008, various proposals to reform American medical care, all of which say that the common problem is the disproportionate increase in costs year in and year out, and no, not one of the presidential candidates has a cost control plan that would sustain itself against any serious academic analysis. So that's the divergence story that I want to tell. Okay, that's obviously these are truncated stories, but that's why we have a dialogue, and Uwe's here to participate, and you are as well. Now let me turn to this third part, which is, and I'm going to do it, I'm going to discuss distortion with a concrete illustration. And of course, the concrete illustration doesn't demonstrate the pattern of distortion. You'll have to stick with me long enough to consider it, and then ask yourself whether it's consistent with other things you know. The story I want to tell is the story of how in 2000, 2001, the buildup of crowded emergency rooms in Canada and the United States was interpreted by our US media. And here's how it happened. Remember, there was a lot of flu in that period of time. And ABC News went up to Vancouver to interview people from the Fraser Institute. That would be a little bit like the Communist Party coming to America and interviewing the Cato Institute. Right? Then the New York Times went up to Toronto and talked to a variety of people in the business school about the problem of the crowded emergency rooms. And someone from the Boston Globe went up to Montreal and did the same thing. Now, at the same time, the Chicago Tribune and the Wall Street Journal and the Los Angeles Times did stories about the emergency rooms in the United States. And here's what emerged. I wrote a piece about this called Two Images Across the Border. The understanding of this common fact, which was emergency rooms were crowded in all these places. Cabs couldn't get their patients into an emergency room. There was difficulty in all the major cities of North America. Here was the interpretation. The ABC journalist was convinced that the crowding of the emergency rooms illustrated the difficulties of Canadian Medicare. This was reinforced by the conversation with Michael Walker at the Fraser Institute. So the impression coming from the Washington Post, the ABC, and I guess the Boston Globe it was, the New York Times did other ones. The impression there was, but for Canadian Medicare, there wouldn't have been a big problem of the emergency room. And yet, in the discussion of Boston, Chicago, and Los Angeles, exactly the same problem was showing itself, but that was because of the flu. Now, if you explain the same thing in these two different ways, I assure you the consequence is intellectual confusion. And the point that I want to make is that we have had perspectives on this which don't distinguish very sharply between learning sufficiently about another system to be able to draw sensible lessons from it. In fact, I would reverse it. There are lots of people who draw lessons from Canada without understanding it, and people in Canada who draw lessons from the United States without understanding these. And in terms of equal treatment, I have to say that for the American scholar who spent 40 years doing this comparative work, the stunning fact about Canadian commentary about the United States is up to about the middle 1990s. Not all Canadian commentators, but the great bulk of Canadian commentators took special pleasure in our problems. I believe that Canadian mental health was actually shaped and improved by the difficulties in American medical care. Every time inflation reports or the lack of insurance was reported, Canadian souls, chests really kind of expanded with pride in medical care. You're laughing, but I believe this is not a laughing matter. It may be funny, but it's not a laughing matter in the sense of truthfulness. Why? Because if you're living next to the elephant, to the south of you, when they sneeze, you get a cold. One thing that really gave people a sense of comparative performance and pride was the extent to which it was assumed from the period roughly in the late 50s all the way through the mid-90s that in this area, Canadian public policy had gotten it roughly right, not perfectly right, but roughly right, that Canadians would not, on the whole, ever face bankruptcy from being ill. That on the whole, if they went to a doctor, the doctor could decide what it is that they thought they should be. There might be some problems about getting into the hospital, but the amount of autonomy between physician and patient, really going back to the old days, was very substantial. That no wallet biopsies played any role in this at all, and that, what's more, you had some kind of budget containment around medical care. So here follow these facts. In 1970, the United States and Canada spent exactly the same proportion of their national income on medical care. A decade later, the United States was spending 9.5%, not 7%, and Canadians were spending about 8%. By 1990, it was 11.5% in the United States, and it was still about 9% in Canada. And by 2000, it was 15%, 14 to 15% in the United States, and 10% in Canada. That means with universal Blue Cross Blue Shield, to use the American example, they were spending dramatically less, and in bed days per thousand and office visits per capita, Canadians got more medical care than the United States did. That, of course, leaves out the technological side. So there was reason for some considerable satisfaction. The mental health thing seems funny, but I think it actually has been very important in Canadian-U.S. thoughts. And what Antonia was saying, which was she was describing the loss of confidence in the future, really was produced in part by an extraordinary fiscal squeeze on Canadian medical care at the consequence of Minister of Finance Martin's effort to transform the payments between the federal government and the provinces. Imagine 2 years in which Canadian medical care actually stayed the same or fell in nominal terms, not in real terms. Extraordinary clash, which actually upset dramatically the nurse-physician large-scale support. That's the background I want to give you for the distortion. I think, let me put it personally, of course there are problems in any medical care system. The major, I would say, law of medical economics is that the expenditures for health care must equal the income of people in the health field, right? It has to be. It's an accounting identity. Uwe, it's not a law in the sense of empirical. It follows from understanding what the words mean, all right? Now, if that's true, then it must be the case that cost containment is contentious. It must be. No system can ever live within a budget without strain because you are postponing what other people would want to be the case because you've got other uses of those funds. So there's no free lunch, as Antonia was saying. But what I want to say is, as a commentator in the American debates going back now to the 60s and certainly to the early 90s and now again in 2007 and 8, let me just give you my conclusion. As an American citizen or as a policy analyst or both, I would love to have their problems in a nanosecond if I had to choose. That's the conclusion I would come to. Now, how does that bear on the lessons that I would want people to draw here? I would not want to urge everybody to jump to the conclusion that I've come to. I've come to that over a long period of study. What I would hope to urge in universities like this one and around the country, and oh my God, the aspiration, which is doomed to fail, to have American media actually pay attention, would be to actually pay some attention to our closest neighbor, not only physically, but our closest neighbor for the kinds of medical circumstances that we have. The dramatic point of difference between 1992, 93, and 94 and today is in that earlier period when the Clinton reform had such a difficult time, there actually was a lot of considered thought about Canada and about Germany and about other places. The GAO did studies of it. It was serious. I'm sure that Senator would know about that. Now, there's unbelievable provincialism. The only experience we're looking at is the experience we've had. If that experience has been bad, where are we going to learn our lessons from? And the other point I guess I would draw there is the reason you want to think cross-nationally and not necessarily about your own history is that your own history doesn't include an example of coping with this problem that's satisfactory. Right? It shows you one or another illustration of a small-scale reform, but it's not, you haven't generalized it. The one thing another system does, whether it's Canada or Australia or Germany, it tells you something about what happens when you universalize coverage. And that is, it seems to me, the central preoccupation. We now have a situation in the United States in which a lot of attention is paid to the snapshot of the uninsured, 46 million at any one moment, or to the movie of the uninsured over any 2-year period when something on the order of 70 or 80 million will experience a period of uninsurance. But beyond that are the numbers of American families who will know somebody, A, uninsured or underinsured, or well-insured but had some difficulty with the insurance company in dealing with actually the bills that came through. So that economic insecurity is now widespread in the imaginations and understandings. So that leaves me with this conclusion. We spend a very large proportion of our national income on medical care, and it would be perfectly fine to spend 16% if we were happy with what we got. We're unhappy with what we got for some very good reasons, which we haven't outlined here. But at the very least, if we're unhappy with what we've got for the price that we pay, it seems to me, not only in universities, but more generally, we should pay attention both to nations that are similar to us in ways, that where there's a kind of natural experiment, and also we should be open to trying to understand whether or not there's anything more generally true over very different systems of medical care. Either most similar system comparison or most different system comparison, but not provincialism, which I would say is the current state of affairs. Thank you very much.
Well, I think it's a little bit hard to top that. These are two exquisite scholars of this issue, and I'm just an economist. I don't know about ethics. I don't know about politics. The only qualification I have is I am a Canadian and I am an American. I think you can have both, right? Citizenships, at least I never inquired, but I assume I still do. And I too was an alien. The thing about the US is when you come here as a Canadian, no one ever asks about it. So I lived here forever, happy. No one ever asked who I was, till once the government wanted to give me an appointment. And it was actually in the Reagan government, Assistant Secretary for Planning and Evaluation. And they said, "Did you know that you're a Canadian?" I said, "Yeah." And I said, "Well, we can't do that." And so that was one reason. And I said, "Gee, I just never got around to it, you know, I'm busy." And the other question, the kids resented Daddy standing in the alien line, always having to wait for an hour at the airport. So it was basically the hassle of the FBI. You know, you got to go get fingerprinted, get asked, "Did you ever sell your body in prostitution?" Actually, I answered this, I tried, but no, there was no market. Then they realized, you know, you actually get asked that question. You know? I told them, who would buy me, let's be honest. The other thing is, Ted says he doesn't differ that much with Antonia, but Ted and I differ a lot on issues I know nothing about, which is, why can't we have universal coverage? Remember, we had this tinkling match over a whole summer long, where I think your view was it's in the structure of the political decision-making process, the way our government is structured, and I blamed it on the electorate. I have a very simple view. It's probably not correct, but 1/3 of our electorate is just apathetic. They're not part of the deal. The other third is not apathetic, but ignorant and misinformed. And the other third is informed, they know what goes on, and not apathetic, but they can't agree, the elite. So it's a very elitist view. The rest of the plebs basically is just totally out there. And the elite cannot agree on what it should be. If we told the plebs, if the elite could agree what our health system should be, we could sell it to the plebs. I think we can sell wars to them. We can do anything. If we tell them we're bombing, they say, all right, bomb. I mean, there's almost nothing that they ever really get engaged in. So I'm a total elitist on top of that. It's totally politically incorrect. And we had this debate, and you probably won it.
No,
but I enjoyed it very much. The other thing is, I'll come back to the issue of value, except the one thing Ted ended up with that probably can be said. I think if I had to bet which has the most cost-effective healthcare system, where by cost-effectiveness economists mean output per dollar of spending, you know, what is achieved per dollar of spending, or the flip side, you know, the cost for per unit of what you achieve. It has got to be true that Canada, which spends roughly half per capita what we do, it's roughly what, 3,200 versus 6,006. Given that people up there are not dying in the street and the images you sometimes hear from here, yes, they do give up some, they stand longer in the queue, some services they might get, but overall, I mean, their infant mortality rate is infinitely better than ours. It's got to be true that Canada, for all you might say about it, has the more cost-effective healthcare system. So if that mattered to Americans, Canada has lessons. And if it doesn't, then it's another story. Now, to my mind, social values do drive health policy. And here, and those social values express themselves in the way healthcare is financed and how the insurance mechanism is structured. It is quite unimportant whether the delivery system is public or private nonprofit or private for-profit. And I sometimes am puzzled that Canadians can get so exercised over whether you might have a for-profit, some clinic, or even a for-profit hospital. To me, that would be quite unimportant as long as they pitch against the same demand side, like all hospitals have to sell to Medicare on the same conditions, exactly the same. Why would anyone get exercised over who owns that thing? And I think that's a sort of a misplaced energy up there to even debate this. Now, the question I would have for our two guests, do social values actually differ? Sort of, Antonia suggested, well, if you look, there is still a fragile but still a plurality that supports our values, which beget the Canadian health system. But Ted said, you know, maybe today the Canadian Medicare Act wouldn't pass, which suggests the values of young Canadians may no longer be the values that actually begot the Canadian health system. And I personally don't know. It'd be interesting to study. I don't know how one would study this. Humphrey Taylor and I once did a study where we had asked people on social values, and we discovered that the US actually was not that different in terms of social values from other nations, which actually strengthens your case that it was the structure of government that didn't deliver on the social value that Americans have. So it could very well be that Canadian and American social values may not differ as much as you sometimes suppose. I personally have come to believe that social values differ much more between the World War II generation and their grandchildren. You know, as I put it to my freshman class, your grandparents believe your position in life is mainly luck, and luck should be shared. And they gave us Medicare and Medicaid, and they were dreaming of a great society. That was the World War II. Why? They were in the trenches together, in the airplanes together. They suffered together. They went through the Depression together. And they realized luck was the main factor. I said, by contrast, you think luck is deserved. I don't know how you come to this, but there it is. And it shouldn't be shared. If you inherited a ton of money, why should you share it when you have contributed nothing to society for the 100 million you may already own? But they really have that feeling. Why should someone take it from me? And I think that probably is a bigger divide than Canada, the US, World War II generation versus today. And the reason Canada is what it still is social inertia. No country likes to change its health system. That's another rule of health reform. It's very difficult to depart from what you have. People are sort of locked in. So that's a question more so than a statement of mine that I would urge you in your future debates to say, is there a difference in your view in the social values? I have a graph, the economics of being kinder and gentler. It's supply and demand, of course, because I'm an economist. And they say there must be a demand curve for services you want to purchase and give to the poor. Right? In every country, the well-to-do do want to help the poor. And nowadays, you buy these in the market, healthcare or schooling, etc. And because I'm an economist and I believe demand curves slope down, I draw it sloping down. And I say what this says is when it's cheap to be nice, you'll be nice more often. And when it's expensive to be nice, you'll be nice less often. So I always say maybe God made it that Canadians and Americans have the same demand for niceness curve, but it's so damn expensive to be nice in the US that we look meaner than the Canadians because it's very cheap. You know, what is a bypass up there? Coronary bypass. Here it's a fully loaded Mercedes-Benz 350 with GPS.
That's total cost. I mean,
Total
you take
cost.
a thoracic surgeon in Toronto and Chicago, which would be the relevant,
Yeah.
it'd be like 50% less in Toronto.
50% less. You see, therefore they do more. It's cheap to be nice. So that's an issue that I really think I'm not qualified to research or talk about, but I'm qualified to be curious about. The other thing is I don't know whether your income distribution, Antonia, in Canada is quite as skewed as ours, and what effect that has on social value and on healthcare. I just looked, Ed Wolf, you must know Ed Wolf, right? Probably one of the most respected researchers on income distribution. And the distribution of wealth is the top 20% of Americans own 85% of all wealth, The bottom 40% in the wealth distribution own 0.2%. You say, don't they own their houses? The answer is no. They took subprime mortgages or second mortgages and blew it on whatever. So they own almost nothing. And that's what I tell my undergraduates. One of my great delights is these people are all going to be 65 with zero assets, and you're going to feed them, even if you hate them. What can you do with them? It's a major problem. But the people who are so rich that they're not part of America really anymore. There's an aristocracy that never takes a subway, never takes a cab, and never doesn't know what a public school looked like. There's that whole thing floating. Are we still a nation in that sense? Or are we not really just a whole group of people sharing a geography? I don't know if that's like that in Canada, that wealth is so concentrated. And the same with income. The top 20% in the income distribution get 60% of all the income in America, and the bottom 40% get 10% of all the income. Whether that, my question is, to us Americans, is it in fact possible to have an egalitarian healthcare system and education system and justice system when incomes are so vastly differently distributed? So I leave you with more questions than any answer. And one final, today's Wall Street Journal has a very interesting article about MD Anderson. Lady went to the doctor. He said, you have leukemia, but I can't diagnose it as well. Go to MD Anderson. And they said, you have to give us a certified check for $45,000 before we'll even see you. And she did get that because they had some assets. And they discovered she had a rare kind of leukemia that they could treat. And they say, now you have to make a down payment of another $60,000 to be admitted because the $45,000 was only for the diagnosis and the other $60,000. And so you have this thing, when you read it almost every American would be very, very upset to say, gee, this goes on in our country, nonprofit, MD Anderson. But then I could ask the Canadians, in Canada, it's inconceivable that a hospital say, give me $45,000 before I even diagnose you. On the other hand, would the Canadians be able to treat this at all? See, that's the real question.
You can't decide unless you do the diagnosis.
Yeah, the diagnosis, but that's of course true, but would they just give up, would they give up hope? Would they give up hope? Let me put it this way. And I don't know about this, but there are all these issues. Americans consider it very important that that be available. In other countries, they would say, you know, something, maybe we shouldn't be doing it if it's so expensive. So that's another question. No insight, just a lot of questions.
Is this on right here?
Why don't you each take whatever time you want? And
We've already consulted. You've been sitting here for an hour. I think the time is here for questions, and we promise to respond to Uwe's comments in the course of the questions and answers.
Write a paper.
No, we'll respond to here. Does this work, by the way? Is that on? Does that work?
question at the back.
Professor Maroney, one of the biggest problems we have here in cost is the success of the trial bar, which means that each physician has to put a tremendous amount of revenue into med malpractice. How has Canada dealt with that problem?
It's really the scale of the practice problem. Antonia wants some help. I'll give her some help.
The malpractice issue is not the same in Canada as it is in the United States. And part of this has to do with the fact that because doctors are reimbursed by the public system and the hospitals, so Uwe was relating to the fact that hospitals are either publicly or privately owned. In fact, in Canada, they're publicly financed, but they're privately owned in the sense that they're all voluntary not-for-profits with their own independent boards. But they have a margin of, what's the word? Reserves. That's one word. And also, what I mean in terms of the malpractice is that they, in effect, are able to, because it's collectivized, doctors are not,
They're not at risk.
in the same way that they are individually in the United States.
And Uwe probably could speak to this as well. I think it's very important to be clear about this. Because then, going back to the 1960s, there wouldn't have been much difference between the treatment. But what's happened in Canada is that the risk or the distinction is made between malpractice on the one side, which is a professional problem, and the financial consequences which have been spread and dispersed in the way in which insurance does. Nobody faces the kind of problem that an OBGYN, for example, faces in something like Pennsylvania or neurologists face in elsewhere. That's really important. I mean, they've got, in effect, provident societies, which is the local medical association, the provincial medical, spread the risk among all the doctors, and you don't have, the second factor is that you've got a legal system in which the loser bears the cost, so you've got some diminution. So if you're looking for a big difference, yes, it's there. But I think you got to watch out here, because many physicians in the United States begin their commentary about American problems with their malpractice costs, which are very severe, don't get me wrong, but it's got almost nothing to do with the rate of inflation which has produced what we're talking about here as a cost control problem. It is personally very devastating, particularly for certain specialties, but if the malpractice litigation went away tomorrow, we would be worrying about costs just as seriously. That's the paradoxical thing. It is terribly important for the morale of American doctors. It's terribly important for the choices of specialty, but it's not important for the cost control, even though in their heart of hearts they all believe defensive medicine explains most of the difference between medical care here and there, and it's not true. So it's a pretty complicated, interesting topic.
I think one should add the malpractice premiums, totally, that are paid in the U.S., are only about 1.2% of total national health spending. So it's not a driver in that regard. And that, of course, reflects all settlements plus the insurer's profit margin. But there is this allegation that we have a lot of defensive medicines that test. Undoubtedly, there is quite a bit of that No one really knows how much it is. Price Waterhouse recently estimated 200 billion, but where on earth would they know? And I sometimes sort of tease physicians. It was the AMA. I said, don't pray too much, God might hear you, because after all, that defensive medicine is income to you.
Exactly.
Right? So if God heard you and got rid of all defensive medicine, your revenue would be down 20%. If that were true. If that were true. So you kvetch about it, but not loud enough that God should hear you.
The defensive medicine issue is one that many doctors in Canada would say in comparison to the United States. But on the legal side too, in Canadian courts, civil cases are not usually decided in jury terms in terms of awarding of big settlements. So the legal incentive for these huge malpractice cases is not as big in Canada.
But let me ask you, as presumably egalitarian, are you comfortable with the idea that with a court case, the loser pays? Wouldn't that be regressive in some way? I mean, one thing about the contingency system is it gives poor people access to the court. Well, normally you wouldn't even risk it.
I think that there's I'm not a legal expert on this, but I'm pretty sure that under a certain income level, you're not responsible.
Oh, you're not.
Yes.
Could you speak to denial of service, comparing the normative health situation in the United States with what exists in Canada? To what extent is more or less service denied when in terms of procedures and so forth? Is there some way to make a comparison there?
No, there are some ways, but they're bound to be contentious, because one way to do it would be to say, all right, one way to measure this would be, what's the probability that someone in Seattle who is short of breath will actually get care for that kind of cardiovascular problem compared to Vancouver, or if you like it better, Manitoba, Winnipeg versus Minneapolis, or Boston versus Montreal. We don't have a lot of data on that. What you hear about are the individual episodes of someone waiting long and dying as they wait for medical care. Rationing takes place in both, but rationing here takes place by income as expressed by insurance coverage. Rationing there takes place by supply constraints, which vary from area to area. So that, I'll just give you a concrete example. In the 1990s, there built up a waiting list in Vancouver General for cardiovascular interventions. And two cardiovascular surgeons in a practice estimated that they had 700 people waiting, which was a big deal to be waiting. And they were claiming that they needed more facilities, more operating time, more cardiovascular surgeons. And they brought this through the newspapers to the attention of the BC Health Commission. And of course, part of the point about accountability in Canada is you have to answer for that. There's actually someone to speak to and to hold to political account, namely the premier of the province and the commission that they're in charge of. So they did a deal. And the deal was that they would buy from Seattle General, which was an identical hospital to the Vancouver General in rough shape. They would do a deal, and they would pay 50% of the rate being charged in Seattle General for people to go down to Seattle from Vancouver, and they would pay both transportation costs and family expenses at the hotel, thus hoping to drive down the waiting list in a way that was satisfactory. Now, the two sides of this coin are there was 50%, 55% occupancy rate in Seattle, okay? Which means that there was a lot of waste going on. And there was 95% occupancy rate in Vancouver General. At the end of 2 years, 125 patients had gone down to Seattle, and both cardiovascular surgeons were struck off the list for having made up a list of 700 for their waiting list as a mechanism to try to get resources in Canada. So complicated, right? I mean, here you had fraud on the part of some earnest pair of cardiovascular surgeons who thought if they built up the waiting list, they would put pressure on the authorities in British Columbia to do so. So it's one of those cases where figuring out exactly how fair is the distribution, we know for sure that and Uwe knows this as well as anybody, We know for sure that we ration access to care in the United States by ability to pay as reflected in insurance. And we know in Canada that they ration care in part by supply constraints. And those two things are just true, and you'd have to do individual detailed studies to get much clearer than that. There's no big prominent element here. It's probably to say that cardiovascular was the biggest problem, and that there's been a big expansion in Canada to deal with the express demand.
Aside from anecdotes, is there anything statistical that gives you
Yes,
an average?
as I said to you, there's more bed days per thousand experienced by Canadians and more office visits per capita experienced by Canadians. Now, if you want to go beyond that and then look at the 10 highest expense technological innovations you would have, except for transplantation, more supply in the United States than Canada by about 1.5 to 1 for most of them. Transplantation is rationed by natural organs, and so you've got that. So there's no question that two things explain the differences between Canada and the United States, mostly, but not entirely. One is they pay less for the same things, and we do somewhat more of the more expensive things. That would be, I think, I would be willing to live with that answer and defend it, not to the death, but to the hospital bed.
There was a paper by Evans that actually looked at the purchases of healthcare across the border. In health affairs about 10 years ago.
That's a slightly different question.
Yeah.
There's another point. Part of the misrepresentation across the border is this imagery of Canadians flooding south of the border to deal with the line. You're shaking your head as if you recognize that. The study that was done suggested about 0.5% Canadians were moving south. About 1/4 was moving north. And the 1/4 moving north was proximate elements, and the 0.5% moving south was to jump the queue that was taking place, done through private insurance that would let you go to the Cleveland Clinic or the Mayo Clinic for understandable reasons, which 50 years ago or 100 years ago people went to Switzerland for.
Actually, there was in USA Today a couple of years ago a study that people who live near the Canadian border, when they have children, babies, they often go north. It's so much cheaper than having them be here. So that it does, well, the specialty stuff, they come here for the transplants, the high tech. But for primary care, sometimes the traffic's the other way.
Kick it.
Yeah, can I come back to Antonia's comments on the sort of decline of phase of Canadians in Canadian healthcare? Wouldn't you say that if you look across countries, in different countries, whether it's North America or Europe, that you would see a decline in phase in government in general, in public programs, including publicly funded healthcare programs? It's maybe not so much the erosion of phase of increasing worrying about the future of Canada's healthcare system, but it's more sort of general decline in support for public programs, although, and it all goes into the same direction, although it's a matter of degree, because at the same time, that's across countries pretty similar, the actual experience of patients with their doctor, provider, hospital is everywhere pretty positive, and those figures don't differ very much. So I'm not sure that it's so much that the Canadians are so much particular concerned about healthcare.
Well, I don't think I don't think you can make that correlation, that it's only the kind of generalized, if you will, erosion in confidence in all government programs and not specific to healthcare, because I think there are a lot of things in the Canadian healthcare system over the past dozen years which speak to specific concerns that Canadians have about access. And the survey, so public opinion surveys tell us one thing about how people feel about the kind of, about how they look at healthcare in the future. But the actual access to surveys that we've seen show that the overwhelming majority of Canadians are satisfied with the care they get. So at the point of access, they're satisfied. However, there is a growing concern for specific things, and the specific things where we find the growing concerns are for the wait times for these non-urgent, what are considered non-urgent surgical procedures in the cataract, hip, and joint replacement surgery, and in the visits to specialists. So certain types of specialist access is more limited in Canada. So on those points, you see a growing concern. And it's a specific one that in those access to surveys that we see. But when I say...
Sorry to interrupt you, but isn't that the same, that other question? If you read newspaper stories week after week about whatever's going wrong without serious substantiation that it's true, then, you know, you start believing that the world is coming to an end.
Well, that's still a crisis in confidence, right? So part of the problem is that when I talk about the fragility of the consensus, it is a fragile consensus, and it's a consensus that I don't think is as strong today as it was 10 years ago. And it's something that is due to a lot of factors. But one of those factors has been a relentless attack, or relentless interest, I should say, by the media. And, you know, I mean, the people or groups that are getting their message out, it's still the same basic debate, right? It's still the same basic power struggle between interests on these particular issues. And the media is one transmission among many others.
Can I push the speakers on something that I'm still puzzling over? It relates to the sort of basic purpose of our session today, and that is the relevance of the Canadian experience for U.S. debate. So what I heard from the two main speakers was that things in the two countries were fairly similar in the 50s and 60s, but then the two countries took a divergent path, whether it be because of different values or perhaps because of differences in the political structures and processes. Now when you observe outcomes, you see that the U.S. system is badly underperforming compared with the Canadian system. So what I want to know is it relevant to think about Canada anymore, given this divergence that's taken 40 or 50 years? And, you know, if Uwe and I both set out to Toronto in our cars, and Uwe uses MapQuest and gets there in 10 hours, and I trust my own judgment to end up in Kansas City or something like that, then how Uwe did it is actually kind of irrelevant to me getting from Kansas City to Toronto. So given that the two countries are very differently situated as a result of past decisions and choices, are there specific concrete things that those of us who are interested in the American healthcare debate can still learn about Canada that are relevant today? Or is the Canadian example more useful for kind of hortatory purposes, but not for specific lessons that can be learned?
Okay, that touches a little bit on Uwe's point too about values. That's the right question to ask, and maybe Antonia and I went too far in pressing the divergence. I mean, let's start again. If you go to a Canadian hospital, you'll recognize that Canadian hospital in all likelihood as another community hospital. The great bulk of them are owned in exactly the same way that St. Barnabas is owned in Minneapolis. The same thing will happen in Manitoba, so don't press that. If you talk to doctors, you'll find they are more fee-for-service doctors than we have in the United States, but the dominant role is still here. Dominant value is still there. So how doctors wish to be paid, have wished to be paid, how hospitals are organized, owned, and so on. I mean, it is, you've got to watch out for them. What we're really talking about is two things, and only two things. One, we both share the view that because different decisions were made in Canada about how to move into universal coverage, doesn't mean that there was a value set so different from them in their case as opposed to ours. There was the same, roughly speaking, the same values. We went down the population road and were blocked in expansion along that road. They went down the service road and got by 1971 that done. We were talking about universal health insurance in 1971, 2, 3, 4. So don't exaggerate that, but there's a consequential problem set up. Canadians over time came to value more the very premises of the scheme that they got, even though that's not what caused it. They came to take pride in exactly the same way Americans came to take pride over the 1960s and 70s in the Social Security system. Both became icons. Third rails not to be touched. After 30, 40 years, the pressures of costs are important in both places, but they've settled some institutional facts in Canada. We haven't. We have to look at them as one road, not that's impossible to take, one road that's different from other roads. And that's what I would say that the danger is getting too hung up on the value differences between Canada and the United States. And instead, I think, going back now to Uwe's point, our institutions, our political institutions, make it easier for minority voices to block action. And that's less so in the Canadian system. And that's part of what Uwe is talking, not value conflicts, but values held by people with disproportionate power behind easier access to the veto points in American public life. And that's what I would say is a big, which means that we will need a bigger shift of public opinion and a bigger shift of political power to produce equivalent changes in the U.S. system.
I mean, one interesting question I would have for Antonia is, does public policy in Canada get discussed in as mildly idiotic a fashion as we do? It's all by labels. So you have Giuliani say, if you do this, it's socialized medicine. Well, that doesn't tell you anything. Today I read McCain doesn't like the other two people's plans because it expands government. That doesn't explain anything either. Maybe government is good. I mean, why doesn't he say a government program would be bad for these reasons? But it's just label, bingo.
If
and
you're
then you have journalists, most of our television journalists are very unintelligent. They really have no knowledge of healthcare. I mean, if you, as Stefan Oppenheimer, does he really know about healthcare? Nothing. Why wouldn't they use people who actually know something about policy when they debate health policy so you could follow up? These people are not capable of following up. The irony of Giuliani is when Mayor Lindsay was old, he was well-to-do, he went broke because he had all kinds of illnesses. Medicare didn't cover everything, and he went broke. And what did Giuliani, the foe of socialized medicine, do? Put him on Lindsay on two fake city jobs, city pay, health insurance and pensions, social insurance. And I often ask people, if socialized medicine is so bad, as you all tell me, why do you reserve that system for your veterans? And then people look at me, the VA, I say, yeah, that's the purest model. So why can't we discuss? Medicare happens to be, it's a survey show that, one of the more popular insurance programs. This is a very simple program, and the providers get paid in 20 days and so on. And yet somehow you have this notion, all you need to say is government, and it ends the debate. Is that the Canadian?
So if you're asking me if politicians are considered to be idiots and journalists are considered to be unintelligent in Canada, I get the answer is yes, of course. Most Canadians do find that politicians are idiots and that their journalists are unintelligent. However, that being said, the debates are different in the two countries because the boundaries around the debates are different. So in Canada, the boundary about reforming the healthcare system is the fact that we have a universal publicly funded healthcare system. So it's what can you do within that boundary that is in the art of the possible.
But if you go back to the origin.
Okay, so if I now, and this is where I want to bring back, go back also to Alan's point or question. I think what's really important about studying the Canadian case, and perhaps I didn't say it as forcefully as I should have in my comments, is that the lessons that can be drawn are what is possible, right? So what was perhaps possible and is possible, but more importantly, why things are different. Because if you drill down into why things are different in the two countries and understand that it's the result of certain political choices that were made, certain types of voices that will be able to be heard, certain types of interest group politics, you understand that the debates that we have today in the United States about healthcare reform are probably not the right debates. Right? And the coming back always to the social values, sorry Uwe, but coming back always to the saw of social values, in effect, doesn't allow us, or doesn't allow Americans to actually see where the blockage is, what the reasons are for why there is no universal health care or health insurance in the United States.
Let me correct though, I think American politicians are anything but idiots. They're very savvy and sophisticated.
That's the way they proceed.
They pitch against these television guys, you can get away with slogans because the television guys don't have the intelligence to follow up.
But the slogans were exactly the same in the late 50s and early 60s in Canada. It's really important not to make that the difference. This is an ideological fight in every place I've ever looked at. You never get away from these are contending views.
Yes.
Me?
Yes, please.
Oh, okay. Would it be okay to raise the question of the Barack and Hillary health plans? And will Hillary's lead towards universal health care faster, or what do you make of this towards the Canadian system?
Well, you have to ask the boss here, who's in charge, whether we can deviate. So
Oh,
We'd all
okay.
be curious
That's
about
why I added the Canadian system, so you can tell me which one gets.
I can give you a two-sentence version, but I can't defend it in two sentences.
Okay.
My two-sentence version is that the differences between Barack Obama and Hillary Clinton on where they want to get to and how big a difference it is in their first steps is not worth very much attention. That's sentence number one. And sentence number two, to support Uwe, the commentators are not well enough informed to be able to confidently stop them from spending so much time talking about trivial differences between two plans which have much greater absences than they do differences. Now that's a contentious view, but it will stay away from Canada if we carry on. This is an area.
But none of those plans are anything like the Canadian health.
No, I knew that, but I had heard that it would be easier for Hillary's plan to move to universal health. I don't know. This is.
I think it would not be easy to move to universal coverage under any plan in the United States. It's going to be a real fight, and it's not going to be settled by phony discussion of differences between two inadequate steps. It's a longer conversation, very important.
That's exactly the point. This is not an issue worth debating, and yet they made it such.
This fellow right here has been waiting a long time.
Oh, I'm sorry. Yes, go ahead.
Like they said at the beginning, there's a strong political impetus to go to sort of universal health care, but when I was looking at the Canadian system, there seemed to be some interesting trends towards privatization, in that there have been private surgery clinics popping up at least once a week, as far as I've been informed. Even Dr. Brian Day, who was the president of the Canadian Medical Association, opened a clinic that was technically illegal, but wanted to service the deficit. So I was concerned on how that kind of system of a universal Medicare would translate to the United States, where we have a population that's almost 10 times that of Canada. And so my question is, what do you think of a health savings account program for the United States, which would still consist of private insurance, but would balance the responsibility between individuals, the government, and the healthcare insurance providers?
Okay, I'll talk about privatization, and then Ted can take on health savings accounts. So what's going on in Canada right now is a change in the debate. But on the ground, there's not a rush towards privatization. So what has changed in Canada is the contours of the debate. So there is much more talk of introducing private mechanisms into funding of healthcare, into public-private partnerships for the building of hospitals, and how certain types of services can be financed. For example, these non-urgent surgical services. There have been court cases to this effect about people taking governments to court for not having what they consider timely access to certain services. So all of this is now, in effect, expanding that realm of the debate. But on the ground, the changes have still been limited. There have been significant changes in Quebec because Quebec was forced to change its healthcare laws as the result of a court case. We've had a new report, there's massive reports. In Canada, one of my economist friends likes to say, we just take, to get better, you just take 2 commissioned reports and call the doctor in the morning, because every province commissions reports, has commissioned many reports over the past few years, and the federal government as well. And in many of these reports, the idea has been, how do we broaden the way we can tax or the way we can raise money and revenues. The problem with Canadians is that it's fine in theory to say we'd like to look at user fees, we'd like to look at other ways of financing, but in practice it's very difficult to tell Canadians who are much more taxed than the United States. I mean, this whole thing about whether you can get universal health insurance without higher taxes. Yes, you need higher taxes to do this. So in Canada, we kind of understand, right? We have high taxes, but we expect something for those high taxes. So when you tell Canadians, not only will you pay high taxes, but then you're going to have to pay, and these premiums for your supplementary benefits, but you're also going to have to pay again if you want to do something privately. People start to, think, where is the limit to how much I'm going to pay? And isn't this supposed to be a publicly funded system in a way to control costs, but also to make it affordable for everyone?
The short answer to your question about health savings account is that health savings account are in some ways the enemy of first dollar coverage, in which access to care is not rationed by ability and willingness to pay. In a way, it's the opposite of insurance. It's internalizing, individualizing the protection against medical care. Now, this appeals to some people, but it's got nothing to do with spreading the cost. It's concentrating the cost at the level of the individual. This we spent decades trying to get rid of. Now, it is true that in the United States, the form in which health savings account has come forward has been attached to a requirement of a catastrophic health insurance plan. And that's important to say, because there's two conceptions, at least, of the purpose of insurance. One is to protect against the flood of the financial consequences of illness. That's catastrophic. It has nothing to do with getting rid of ability and willingness to pay as an allocational device. It's everything to do with not driving people into poverty by being sick. That's different from prepayment, or the kind of Blue Cross Blue Shield plan I was talking about, which the Canadians' arrangements reflect. And you need to be clear about the differences between the two. And finally, I would say, I would urge you to think this way. This goes back really a little bit to your values point. The people who try to describe the United States medical care arrangements in terms of a dominant picture forget that there really are 5 Americas in medical care. One of them Uwe's already referred to. We've got a national health service. It's called the VA. If you're a veteran, entitlement to the VA, if you're wounded, comes with your service to the community and the risks you've incurred. And there's no significant barriers to entry if you satisfy that entitlement. The second one we've got is Medicare, which is German-style social insurance, exactly the Blue Cross Blue Shield conception of separating out your experience of illness from your paying for illness. The third thing we've got is European poor law arrangement. It's called Medicaid. If you're poor enough, you get medical care. That's also part of our value system. The fourth one we've got is private health insurance, which used to be done entirely at work. That's been fraying, but that's a fourth one. And then the fifth one we've got is charity medicine. It's the bad debt that's experienced at hospitals or in doctors' offices, which are allocated differently. So the 5 different systems have different value components. And what I would urge you to think about is what's desirable, not what's constrained by a single value set in this area. People got agreement. I think it was right. If there were more agreement among the elites about which of these 5 schemes ought to be expanded, we could actually do it, but we don't have that agreement.
Ted and Antonia have done a publication and we brought some extra copies, so anybody who's interested in reading some more about this debate, welcome to help themselves. And I wanted also to acknowledge that this is a publication that was sponsored and encouraged by the Canada Institute at the Woodrow Wilson International Center for Scholars in Washington, D.C. And we have the director, David Biet, here. And so just to thank him for sponsoring the research that went into this talk. But most of all, I want to thank Antonia, Ted, and Uwe for a very stimulating session. So thank you very much.